Now let's have a look at these pictures. These are the pictures of the foot of a diabetic patient. You can see infected wound on the dorsal and the ventral surface. When you see such a foot, what do you do next? Clinically, you go and look for the presence of neurology. What is the pain and temperature sensation like in the feet? What is the light touch? What is the other dorsal column sensation position like the joint position sense and the vibration sense? And then you check the vasculature of the foot, the dorsalis pedis artery, the posterior tibial artery, and also look for the presence of capillary refill time, because sometimes the arteries may be palpable but there is a problem in the microcirculation. Then you check for the diabetic control. Diabetic control can be assessed if the patient has a record of spot blood sugars, or you can get help from hemoglobin A1C. You can also go for the presence of other complications of diabetes like neuropathy, the retinopathy, or the nephropathy. And then you go for the radiological imaging of these uh, infected areas. Plain x-ray may be helpful. You can go for different type of scans like indium 111 labeled scans, or you can use gallium labeled WBC scan. You can go for an MRI, and you can also do a PET scan. So these imaging, they help you to find out what is the extent of this disease. Now this is the x-ray of this very patient. You can see there is destruction of bone. Sometimes similar picture is seen in the Charcot foot, which is because of the diabetic neuropathy. So inflammatory markers and some of the imaging techniques, for example, the PET scan or MRI, they can help differentiate this is osteomyelitis or this is just destruction of the joint because of the sensory neuropathy. But if you see this X-ray is really classical for the osteomyelitis caused by the infecting wounds, not the Charcot type foot. When you get this foot, you go for the cultures to identify what's the pathogenic organism. Meanwhile, after sending the cultures, you can put the patient on appropriate antibiotics. The more common organisms are staphylococci, the streptococci, and pseudomonas, and then you can have some anaerobic organism. The antibiotic of choice is usually coamoxiclov with metronidazole, and sometimes you can also use clindamycin until the report of the culture of the affected area is received. So you can provisionally put these patients on these antibiotics because these are generally community acquired infections. So this is what is done briefly when you see a patient who's got diabetic foot.